We're here at the Old Operating Theatre for the launch of our new campaign, The Evolution of Medicine Through Warfare. We hope you enjoy this video.
Distinguished guests, ladies and gentlemen, welcome to the Old Operating Theatre. My name is Guy Benson and I am the military veteran, having served with the Queen's Colours for over 40 odd years. It is worth noting that I've deployed operationally to the Falklands, Northern Ireland, Iraq and Afghanistan. In 2021, I decided, however, to get a real job and so joined the NHS and now work for Professor Tim Briggs. In terms of this evening's talk, it's worth noting that this presentation is the launch event for a series of presentations which culminates with Waterloo 2022 in the summer. Before we started, I thought it would be useful to give a bit of context and background. In the past 12 months, we have seen the evacuation of Afghanistan and just a week ago, the invasion of Ukraine. This has thrown up all sorts of mental health issues. There are also some significant anniversaries too. The 40th anniversary of the Falklands, the 40th anniversary of the Hyde Park bombings here in London. All that said, this evening I am thrilled to be able to introduce you to some of the very best people in their field. Their aim is quite simple, to guide you through the evolution of the military medicine through the campaigns. Up first is Professor Tim Briggs Cbe, a brilliant orthopedic surgeon. Tim was appointed to the top job of Director Clinical Improvements for the NHS in 2019. He's also the national lead for the Veterans Government Healthcare Alliance. He cares passionately about all patients and has made it his personal mission to drive down unwarranted variation and disadvantage. He leads from the front and has visited each NHS trust in England at least twice, and there's 212. Tim, over to you.
So thank you, Guy, for that very nice introduction. You can tell he works for me, can't you? And you can tell he was a serving soldier, and I've never served, I have to say, although I've always been passionate about the armed forces in my whole career. And what I'd like to tell you today is a little bit about that and the history of it. So I published this report in 2014 based on my clinical experience at the ROH, where I was seeing both serving soldiers and airmen and naval personnel and also veterans. And I was seeing things like we were seeing in the NHS, where I thought we could have done things better. They could have been treated earlier. And I felt that the NHS owed these individuals a huge amount and we needed to improve things. So we published this in 2014 about enhancing the care for both serving personnel and veterans. And my mantra was always, if we get it right for them, because a lot of advances over the last 200 years in the battlefield have made their way into the NHS, we would then improve care for all. And it got a lot of support, and we're now making really good progress. And that is our purpose. And what we're trying to do is develop, share, and drive implementation of that best practice, which will improve and also improve it for all patients who use the NHS, because veterans actually are NHS patients. And to date, we've now got 109 trusts signed up to the VCHA, and they're veteran aware, and that's the what they receive on the right. And it is making a real difference. And it's a privilege to work with Guy and the team that we have, because there is no doubt by March next year, we should have all trusts in England signed up to this, and we will see again a step change improvement for veterans and also for everybody else. There's a real close relationship now between the Defence Medical Services and the NHS. They work, collaborate together, and that is, I think, a really good thing to see, because we're all together. We've got to be collegiate, and we've got to make sure that we learn from each other going forward. So how did it start? Well, it's quite interesting when you go back to it. When the tourniquet goes back to Alexander the Great and the Romans, and it was used to staunch bleeding and aid amputation. The stretcher made its first appearance in 1380. And there's a medieval knight being brought along on his stretcher. And we've always been trying to make, especially as an orthopedic surgeon, special instruments. Well, we weren't the first. They did that at the Battle of Shrewsbury for Prince Henry, when he got an arrow in his face. They had to make a special instrument in order to extract it. Ambulances go back as far as 1487, but really I think the father of surgery was Ambrose Paré, who he pioneered the modern battlefield treatment with dressing of wounds and using the ligature for vessels. This man, Dominic Jean Larrey, was an amazing individual. His only problem was he was French, and he was on the French side, and he was one of Napoleon's favourites, and he cared passionately about the men. And that quote by Wellington at Waterloo I thought was really, really something special, where he said, "Give the brave man time to gather up the wounded," and saluted the courage and devotion of an age that is no longer ours. And that was, he said that about Larry. And below that is Larry doing an amputation. He could do an amputation in 2 minutes. I mean, absolutely extraordinary. So Battle of Waterloo was an interesting, I used to play with my soldiers as a kid. I used to run this every Saturday at home. And I always wondered why he didn't win, but anyway, he didn't. And the thing was, it was fought on one day, 55,000 dead or injured. I mean, the numbers were phenomenal. And everybody remembers Lord Uxbridge for losing his leg. But what is amazing is before that happened to him, he was in charge of 15,000 men and 44 cannon. He'd had 9 horses shot from under him during that day's campaign before, indeed, he's lost his leg. And when you look at it, the density of the battlefield and the injured was around 2,200 per mile of front because of the way they were lined up, their columns and the phalanxes. And you compare that to the Somme, it was 234 people per mile of front. And the medical services were frankly overwhelmed, to be honest. And many of the casualties were just left out in the open, and they were there for up to 4 days, and they bled to death on the battlefield. And William Hay, who was of the 12th Light Dragoon Guards, went round the battlefield 4 days after the battle, and the Prussians were walking the battlefield and shooting the injured who they thought were beyond help, because the medical services were frankly just overwhelmed. So what was there in those days? Well, it wasn't a lot, I have to say. There were 12 stretchers per battalion. There was 1 regimental medical officer per battalion, and he had 2 assistants who were called mates, who were very rudimentarily trained. And then when they got to hospital, and there were 5 temporary hospitals around Waterloo after the battle, and they had a consultant, they called them hospital surgeons, and there was 1 per 1,000 soldiers. I mean, absolutely phenomenal in terms of the paucity of care that they got. And again, they had hospital mates who were responsible for the day-to-day chores. Again, they weren't that well trained. They did most of the day-to-day chores. And if you wanted a physician, well, it was 1 per 2,000 soldiers. There were no nurses. You were dependent on those that had either been lightly wounded or indeed the wives or the girlfriends who were with them. But again, dirty hands, grasping dirty instruments, excessive bleeding, no anaesthetic and no antiseptic. So the mortality rate was significant. If you were lucky enough to survive, you got treatment and recuperate in one of the 5 temporary hospitals. That decision was then made whether you were fit to go back to your regiment or were you to be discharged. You were paid off, and then there was nothing. There was no safety netting as we have in the NHS today. You were just out on your own, and you depended on charity, and you depended on family and friends. And if you're unable to work, it was a real problem, and you relied on charity. The Crimea War, and everybody remembers Florence Nightingale from that, and she made a significant contribution to cleaning up the water and clean sheets and bandages, and they were well fed and cared for, but the medical treatment didn't really change very much. And again, when they were out of hospital and they couldn't serve anymore, discharged into the wider world, again, it was charity that was responsible for looking after them. Anesthesia wasn't until 1847 when a Russian surgeon did the first field operation in the Crimea War. And then Lister came along, and he was the one really was about antiseptic and sterile surgery. And where he got the idea of using carbolic acid from was, when I'm not working, I'm a farmer. And in the old days, and when you go back to that time, they used human raw sewage to fertilize the fields. But what they would then do, because of the smell, they would then spread carbolic acid over the fields. And he noted that the cattle that then grazed on the fields did not become unwell. So he said, it is safe for cattle, it will be safe for humans. And that was how it transferred into becoming really how we got onto instruments, and clean surgical wounds. And he really is, I think, the father of modern surgery. But if you go to World War I, there were no antibiotics. In World War I, pneumonia, dysentery and TB continued to claim a significant number of victims. So World War I was just on a different scale. So we had 1,000 days, 900,000 dead, 2 million injured, and the sheer magnitude of the casualties meant, well, everything that had gone before was useless. They had lost Lister's techniques. There were new weapons, including gas, of course, and initially it was all about early evacuation into discharge, into civilian life, and again, as before, no support, relying on charity. And then this man, who was an orthopedic surgeon, he was at the Royal Robert Jones Hospital up in Oswestry, and he became the founder of the British Orthopedic Association and was president in 1921. And he worked on the Manchester Ship Canal, where they had 5,000 navvies who were building this canal. And again, injuries were very common. And he was set up to deal with these casualties, first aid posts, 3 receiving hospitals, each with a medical officer. And crucially, what he used was the railway to move the casualties away from those hospitals into the main hospitals. And Girdlestone, again, who was a very famous orthopedic surgeon, said for 4 years this industrial battlefield provided Robert Jones with a wealth of experience both in the organisation and the surgical treatment of accidents. So in World War I, when they started to see these mass number of casualties, there was only one individual who was really capable of dealing with that and setting up a new way, and it was Robert Jones. And not only did he do that in terms of setting up the system for evacuating casualties, he brought what he had learned from the Manchester Ship Canal. So if you had an open femoral fracture at the beginning of World War I, your mortality rate was 80%. When Robert Jones came in, what he did, they cleaned it properly with debridement, antiseptic, relearnt the workings of Lister, stabilising the fracture. They used a Thomas splint, reduced the mortality rate to 20%. And all that knowledge had come from his work on the Manchester Ship Canal. And the other thing he did, he was responsible for reorganising what we did with our mass casualties. So what we had the regimental aid post right at the front line. They went back to the regimental aid post, and then from there they were diverted to the casualty clearing stations. And just give you an idea of the sheer scale of the casualties, at the Battle of Somme in 1916, in July, over 111,000 men were injured on the Somme. And that's number 36 casualty clearing station on the right, and they had 11,000 admissions to that hospital within that month. And the idea was to treat them, stabilise them, then use the railway back to the Channel ports. Then they were put on the boats and they were transferred to England. And what's amazing is by the end of the World War I, we had 250,000 beds for these injured men. And there on the right is where I work at the RNOH, that is Matron's Lawn. And there we have some French and Belgian troops with the nursing staff. Believe me, you're still not allowed to go on Matron's Lawn unless you have been, it's a very special occasion. But it just shows everybody pulled together to absolutely make sure that we were treating these patients efficiently and effectively. And a lot of it was Robert Jones who set up these establishments to manage these patients in a certain way. The injuries were horrific. 12% of all wounded men had facial injuries. We had 280,000 men returned home who were permanently disfigured. And we also saw shell shock and the first thing about post-traumatic stress, mental health issues. And really it was by W.H.R. Rivers, who was a physician up in Edinburgh, who really was the one that first recognised this and just wanted to treat these individuals and did so. Now, the reason I put this up is who was responsible at the front line for doing this work. Now, if you've never been on a battlefield tour to the World War I, you should go. And one of the places you should go is to the grave of this young man. He's Noel Shabazz. He was a twin. He had a twin brother. And talk about talented families. He went to Oxford with his brother initially, where they both just happened to run for GB in the Olympics of 1908. And then when they finished that, his brother went to become a vicar, and Noel went up to do medicine at Liverpool. And they realised that what was coming. So that's the first 10th Liverpool Scottish. That's what he joined in 1913. And then he went with his men across to Belgium and served there through 1915, where he was mentioned in dispatches, then was awarded the Military Cross. But then at the Battle of Guillemot in the Battle of the Somme, he was awarded his first VC. And what he did for his men was phenomenal. In the most appalling circumstances, he would not leave his men out there in no man's land. He went out time after time to bring the men back to the dressing station. And just give you an idea of the losses that they suffered, 85% of their officers were killed, injured or missing, and 50% of them, almost 50% of the men in his battalion also were killed, missing or injured. So it just showed what he did, and that was his citation in the London Gazette. But it didn't stop there, because he was then involved in the Third Battle of Ypres, which was Passchendaele, which began in 31st July 1917 and ended in November. And it just coincided with the worst amount of rain ever for that part of the world. And you can see that the battlefield was an absolute quagmire. And if you stepped off the boards, you would disappear and you were very rarely seen again. And he was involved in an action, and again, he was awarded his second VC. He would not leave the battlefield and died of his injuries on the 4th of August, 1917. And if you go there, and I wanted to go to his gravestone, it's there on the right. He's buried in a little cemetery called Branderhock. It's got about 70 men in that cemetery, and he's the only gravestone on the Western Front that is engraved with 2 VCs. The only medal they engrave is the VC. And when I went there on a miserable November day, the number of fresh flowers at his gravestone was unbelievable. And so when I wrote my report, I wanted to use his, because without their input, many more men would have died. And these sort of people are just astonishing. And that is his father. And his father was the first Bishop of Liverpool. And that's the letter from Lord Derby to his father about the citation for Noel, although Noel had sadly died. And it was phenomenal. And they are just a phenomenal family. So again, after World War I, it was exactly the same. So if you go into the 1920s, some 80% of the unemployed were ex-veterans, and they were all in need. And in civilian life, the care was variable. And even in those times, I've got a piece of paper at home. My great-grandfather worked at the fruit and veg market near the London Hospital. And I've got a letter from the governor there thanking him for his donation to the London. And that's how these hospitals survived. And if you look, the Poppy Appeal came around because we needed to look after these veterans who were a lot unemployed, and they were absolutely in need. If you then move forward to World War II, the numbers of killed and injured, wounded, is very, very different for many in Obviously, we had hospitals at that stage, and we were able to see great advances again. And Alex is going to speak about that, about plastic surgery and East Grinstead and our fighter pilots, and what the work was done there. So we then went, the NHS was founded in 1948. And then once that had happened, we were now linking in not only the serving individual, but we were able to look after those that had served and now were veterans, along with all NHS patients. So I'm going to hand over to
Nigel.
You, Guy.
Thank you. Ladies and gentlemen, I'd like now to hand you over to Colonel Nigel Tye. He is another outstanding surgeon who specialises in trauma and vascular surgery. He balanced his career between clinical practice in both a civilian and a military context. He is a member of the Airborne Forces Brotherhood and is wearing his maroon tie. I'm sorry I didn't wear mine this evening. And is deployed on numerous operations. Nigel, over to you.
Very much indeed. Thank you very much, Professor, for that tour de force. So your task was to compress 60 years worth of military medical advance into 15 minutes, and mine is to compress my small experience into 15 minutes. I hope that I can do it justice, because it really was a revolution for me to observe the improvements that came on board so swiftly from my first deployment supporting 3 Para Battle Group in Afghanistan on Operation 4 in 2006 through to even my last deployment somewhere else last year. The rate of change is unprecedented. So what lessons did we learn? Well, the first thing we learned was that the echelon care system, which Professor Tim spoke about, works. It works really well. It's a tried and tested system, and I have colleagues here in the audience who are at the sharp end, this end here, treating the patient near the point of injury. But no matter how sophisticated that care at the point of injury, it ain't going to work if you can't get the patient back to the sophisticated role 2 or role 3, even more sophisticated role 3. Thankfully, in Afghanistan and Iraq, we had air supremacy, which meant that we could evacuate them through rotary winged assets. And it's doubtful, judging from the way that modern war is evolving, that we will work in those circumstances again. An echelon care system only works, though, if you're truly working in a system. And what do I mean by that? Well, again, Professor Briggs knows all about evaluating care systems in the UK through data and through assessing which units are underperforming and how they're underperforming compared to the best performing units. We had to knit together a semblance of the same kind of work very rapidly that Professor Briggs has introduced in latter years on the hoof in 2006 and 2007, learning from the Americans, compiling data, looking at metrics, and engaging with this sort of continuous audit cycle with an OODA loop, an observation, orientation, decision, action loop that was usually measured in days rather than the months or years that the National Health Service has to contend with. And it was this systemization and exploitation of data that really allowed us to introduce change rapidly and to make the case for more resource when we needed it. My role 1 friends will know all about the kind of technologies and innovations that are now deployable at point of injury. And they consist of the simple, such as the elasticated pressure dressing and the tourniquet, through to the more advanced hemostatic medications, which allow concentrated clotting or better accelerated clotting of blood. Now, the tourniquet, which Professor Tim mentioned, when I started in the reserves, because I was initially joined 144 Parachute Medical Squadron back in '99, and when we looked through our kit and tourniquets, we were told very specifically never to use them because they were an instrument of the devil that sometimes saved a life, Most of the bad rap that tourniquets got was based on analysis of cases in the developing world, typically mine strike injuries where a tourniquet was applied, long evacuation times, and by the time the patient reached an ICRC hospital, the limb was dead. And even if it wasn't dead, when the tourniquet was released, the subsequent flooding of metabolic products caused immediate cardiac arrest and the patient died. So it's unsurprising that it became an instrument of the devil, was mocked. But the combat application tourniquet is now normal business and, of course, has migrated to the streets of London as well. The much famed medical emergency response team exploiting CH-47 Chinook was something that was developed and introduced, I'm proud to say, by 16 medical regiments on operations in Afghanistan in 2006 and subsequently refined and expanded by the Royal Air Force, such that the team on board, consisting of an emergency medicine or airway trained doctor such as an anaesthetist, accompanied by an RAF emergency nurse and 2 RAF paramedics, we're able to deploy the full suite of advanced trauma life support interventions, including chest drainage, airway control, and latterly the introduction of blood and blood products. And there's no doubt that if you speak to many veterans who had to initiate a 9-liner, the call to evacuate a patient, that the sight and sound of the CH-47 coming in to take their injured colleague away was a main bulwark of morale in knowing that this was available to get the patient the best care at the best time. But it wasn't just the British effort. This slide illustrates a UK patient being evacuated via US Pedro assets. Pedro was the call sign given to US parajumpers working for US Air Force, essentially paramedics, combat-trained paramedics. And because their airframes were upgunned compared to the CH-47 and smaller, they were able to deal with a slightly hotter LZ than the CH-47 and were able to extract casualties as well. It was a joint evacuation chain. And what kind of procedures and lessons did we learn? Well, we learned to use good evidence from our civilian colleagues in the United States, and we were able to utilize evidence that suggested that we should very carefully calibrate the amount of resuscitation fluid we give to patients, lest we resuscitate them too much, over-dilute their blood and lead to further bleeding. We were able to understand the importance of the golden hour concept, which was something which we were ourselves and the Americans were able to parley at the highest levels of defense, right to and including this gentleman here, who's the Secretary of State for Defense in 2009, Robert Gates, who introduced the golden hour ruling, necessitating that the key performance indicator for evacuation of a patient from point of injury through to arrival in a surgical setting was 60 minutes. And when I was leading the clinical components of Bastion Field Hospital in 2013, every time that a patient came in beyond 60 minutes, I had to compile a nauseating amount of paperwork, which then got faxed and sent off to some US desk in Washington and was then reviewed personally by Gates every week. So he would personally review the 60-minute KPI in order to introduce or in order to make sure that we were performing as we should do. The trauma team response we're all familiar with in civilian street, and it was deployed to good effect on operations. But the real added value in terms of technology that we could utilize in that first resuscitation and evaluation was the CT scanner. This one's getting a service. There were very few events where it was getting a service. It was utilized pretty much around the clock. But it wasn't just the equipment, it was the way that we were able to use it. So in NHS practice in 2006, if you wanted a CT scan of something, you had to go to your radiologist and ask for a CT of a particular part of the body, the brain, the pelvis, the liver, etc. Bastion, we didn't do that. We imaged everything all at once. The scanogram enabled, or the Bastion traumagram enabled us to make rapid diagnosis and perform the appropriate surgery without having to undertake multiple serial imaging requests. What kind of injuries were there? Well, we all know really that the majority of injuries, particularly later on in the war, were caused by improvised explosive devices, and the kind of injuries that we would see are illustrated through this board here. So this patient has bilateral amputations, he's had cat tourniquets applied, he's also got an injury to the right arm. So he was probably the person activating the pressure plate who took the main impact of the force of the explosive. And someone further back in the Afghan snake, perhaps 5 meters back, has just sustained relatively light injuries as a result of frag. So operating on these patients proved a challenge, but resuscitating them proved a challenge as well. And we had to learn very quickly that the old methodologies of using transfusion, so that's essentially packed red cells by themselves with the odd bit of plasma, didn't cut it, didn't work. On this anaesthetist glove, they've written down how much product they utilized for one of these patients. So you can see 3 platelets, 2 cryoprecipitate, 29 plasma, 33 red blood cells, and interestingly, 2 of whole blood. So the live donor panel's been activated, whole blood, fresh, warm, whole blood has been given to this patient. And we were able to lobby our chain of command to institute the correct equipment and the amount of blood that we needed in order to deliver this, because we knew from research from our colleagues in the US that the more old-fashioned your transfusion policy, in other words, the more red cells and the fewer amounts of plasma that you give, the more likely patients are likely to die, which is this black graph here, appropriately coloured. And the more likely you were to get survivors with a higher ratio. So transfusion policy was dictated by research, by experience, and by a receptive chain of command who were able to listen to us, enable us to publish our stuff, and then to issue the right policy letters to get resource on the ground quickly. And the resource looked like this. Simple refrigeration, able to take large amounts of blood incoming from Birmingham. 40 years since the Falklands War. Why am I showing a picture of HMS Sheffield? Because it's instructive to understand that the use of damage control as a philosophy became business as usual in Iraq and Afghanistan. What do I mean by damage control? It's a naval term, meaning that in order to address a leaking compartment or some damage to the ship, sometimes it's necessary for crew members to seal off compartment at the risk of vital equipment or even life occasionally in order to save the ship. And it's exactly the same philosophy in battlefield surgery. I'll just skip back one because this is the main operating theatre in Bastion. It's actually 3 operating theatres in one space. You can see the number of people looking after each casualty. It doesn't help to try and execute definitive surgery when the patient is physiologically unstable. Rather just stop bleeding, get contamination control, come back and sort out the fancy stuff the next day or the second day or the third day. I'm just going to show this slide, sorry, to Professor Briggs, because I gather this is not what a pelvis is meant to look like. And this would be the typical kind of injury seen when a patient has received the full force of an improvised explosive device. The pelvis has been distracted, opened up and broken in multiple different planes. And this is the type of patient that would require damage control surgery. I'm a vascular surgeon, so I have to show you some injuries to some vessels. Please indulge me. Instead of actually going in and repairing these vessels definitively, all we would do is to put in some plastic tubing, bridging the injured part, thereby restoring perfusion to the limb and buying time for the patient to have other surgery, perhaps some resuscitation intensive care, and bring them back 24 hours later for the definitive procedure. So damage control was the way that we lived our clinical lives. And you can see how much calmer it is. 24 hours, 48 hours later, there's a much better environment to perform definitive surgery. The gentleman in the Union Jack cap there is Lieutenant Colonel Shahan Heterachi, one of my plastic surgical colleagues, the first plastic surgeon to deploy in Bastion, where we had lobbied for reconstructive surgeons, and the chain of command listened to us, and they were critical to the success of our management of our patients. It's not just about surgery. If there are any anaesthetists in the audience, this is my tribute slide to you, because I understand that waking up from an operation can be intensely painful, and we were able to introduce techniques which are pretty much par for the course in a civilian setting, but which were radical for a military setting. So regional anaesthesia, patient-controlled analgesia. These were things which had not been introduced prior to our experience in these campaigns. And then once the patient has been treated, they go in the flying intensive care units manned by our RAF CCAS teams aboard a C-17 Globemaster, who are on 24/7 standby to come and take these casualties back. And I pay tribute to their professionalism, doing an exceptionally difficult job managing very sick patients whilst in the air. I couldn't imagine doing that job. And then bring them back to our Roll 4 setting, which included Queen Elizabeth Hospital, Birmingham as the main setting, but other partner hospitals as well at times. And here, embedded military clinicians working side by side with their NHS clinicians were able to do those 3rd, 4th, 5th, 6th, 7th, nth surgeries to get the patients to a state where they could be discharged for the rest of their journey, which involves, and we'll shortly hear about that. The National Audit Office are not a group of government employees who frequently dispense praise, but Defence Medical Services did earn their praise when they looked rationally and calmly at our performance. What does that performance look like in real life? Well, this is a young soldier, Worcestershire and Sherwood Forester, who, as you can see, he's got his minimi there. He's about to go on patrol. He was being photojournalist accompanied, and he went out on patrol, and he was shot. And he was shot in the low abdomen. And you can see that he's had an Israeli pressure bandage applied. He's got a drip in situ, but he's not being flooded with crystalloid. You can tell how shocked he is. Look at that, the paleness of his skin. He was attended to, went through the casualty evacuation chain, was rescued by the MURT, taken to Bastion, had damage control surgery. His blood pressure was 60 systolic on arrival, which is close as any human being can get to in terms of a low blood pressure without actually expiring. And he was then evacuated by CCAS to Birmingham, and that was him 14 days post-injury. I think that photograph speaks for itself. But remember, the National Audit Office, they like figures, and they did some homework, and they looked at our survival rates, and they said that for every 4 casualties that would have died in previous campaigns, collectively, we managed to save 25%, which I think is testament to the endeavours that went on. Thank you very much indeed for your attention.
It gives me enormous pleasure to introduce you to our next speaker, Miss Alex Crick, who is one of the most formidable and best plastic surgeons in the UK, maybe even the world, actually, Alex. Alex is an inspirational person and hugely respected by healthcare clinicians, the MOD, and maybe more importantly, her patients. I think I read somewhere as well, Alex, that you perform more reconstructive operations on the Afghanistan military cohort than any other plastic surgeon. So I know we are in good hands. Over to you, Alex.
That was a little bit more of a build-up than I was hoping for.
I'm sorry.
So plastic surgery is a widely misunderstood specialty. I think that's fair to say. The origins of modern day plastic surgery arose from the experience that we had with the gunshot injuries and burns from the First and Second World Wars, happily coinciding with the development of safe and reliable anesthesia and of antibiotics, as we've heard already. I specialise in limb reconstruction and for the most part trauma and the consequences of trauma. Reconstruction aims to achieve primary uncomplicated healing, relieve pain, and restore both form and function. So aesthetics is certainly an important consideration, but usually not the most important for limb reconstruction. We've heard a little bit about the advances in plastic surgery from the First and Second World Wars with the likes of Gillies and Mackindoe, you may be aware of. But it was during the 60s where there was great progress with development of microsurgery, initially revascularization, reimplantation of the forearm, the hand and fingers, and then toe transfer for thumb reconstruction. What we needed was an operating microscope to give us stable, high magnification, the right instruments, sutures, and the right technique for the anastomosis of small blood vessels. The term microsurgery was coined by a vascular surgeon, as you probably know, Nigel, in 1960 when he was Jacobsen repaired a 1.4 millimeter blood vessel, and and it took the whole of the decade really for people to develop all these other aspects of microsurgery for it to become a reliable undertaking. That photograph on the right there is an electron microscope image of a microcircle suture tied around a human hair, just to give you an idea of scale. When this was combined with an improved understanding of the vascular anatomy, particularly of skin, microsurgical limb reconstruction with the use of free flaps was born. This is the most powerful technique that we have as plastic surgeons far more powerful than the random patterned tubed pedicle flaps that were deployed by Gillies and Mackindoe in the First and Second World Wars. So a free flap is the transfer of tissue from one part of the body to another, with the blood supply disconnected and then reconnected using a microsurgical anastomosis of the artery in at least one vein, so that it is immediately perfused, unlike a skin graft. And with experience, free flaps became a safe and reliable undertaking, and just in time. So these are, from my point of view, very exciting photographs. These are photographs of the very first free flap that was used to reconstruct a limb injury, undertaken by Ian Taylor in Australia. And that's a groin flap for a defect on the lateral aspect of the ankle. So why is it needed? Secondary reconstruction, that is. Well, IED blast inflicts incredibly high energy injuries with massive zones of injury, multiple severe injuries. But these are young individuals. They're injured in their physical prime. And when you combine them with all the extraordinary medical care that we heard from Nigel from point of injury onwards, we now had a cohort of unexpected survivors, a phrase that is often used for this group, who presented an extreme challenge surgically for secondary reconstruction. And that's because of the nature and extent of their injuries that were previously unseen. So this slide gives you an idea of the numbers involved. If you think back to the numbers that Prof. Briggs mentioned from the previous conflicts, the numbers are relatively small. But of note, if most people have been injured by an IED blast, it is very likely that you will be seriously or very seriously injured. It is very likely that you will be an amputee, and at least 38% of amputees had multiple significant amputations, i.e. an amputation above the level of the ankle or wrist involving more than one limb. So when does secondary reconstruction start? Once you are well enough to be discharged from hospital, admission to the Defence Medical Rehab Centre at Headley Court, Surrey, that's the photograph on the left. It's now at Stamford Hall near Loughborough, which is the photograph on the right. That was planned either directly from hospital or from home for intensive residential rehabilitation, including prosthetics. So acute reconstruction aims to salvage life as a priority, but where possible to salvage as much anatomy as possible, because this keeps the possibilities open for secondary reconstruction. And secondary reconstruction starts when you are healed or when healing is no longer progressing, when you're recovered physiologically as far as possible, and once rehabilitation has started, maybe a year or so after injury. And I started soon after I was appointed as consultant attending Headley Court with Rolf Birch, who'd started the peripheral nerve injury clinics at Headley Court. And that's how I came to meet a lot of the patients that I've treated. So what is secondary reconstruction? So this is Baz, he was an ML in the Royal Marines, and he was injured by a dismounted IED blast, so i.e. he was walking and detonated the IED himself. He's sustained a lot of injuries and had lots of surgery already. So he's had a laparotomy to control bleeding from his transfemoral amputation. He's had another laparotomy for bowel injury. They've tried to salvage his right hand using a free flap from his back, which unfortunately failed, and that was replaced with a pedicled flap from his abdomen, which is that strange square on the right side there. He had fractures of his left forearm, which required internal fixation, a femoral fracture as well, which required internal fixation. That had to be replaced for an X-fix because the metalwork was infected. And he's had lots of skin graft taken from his thigh, his leg, his abdomen, and that's been used for the wound on the back of his thigh, his forearm, his stump, and for the flap donor site on his abdomen. So he's already had over 40 operations, and I didn't mention his ear and eye injuries as well. So when we meet, he explains what his problems are from his point of view, what his priorities are, and then we assess what we think is achievable surgically. So we make a surgical plan, and that involves a series of operations, a sequence with combinations and the right sort of intervals to allow for healing, recovery, rehabilitation, and a bit of rest and a bit of other life that has to be tended to. He needs 3 free flaps, and he has only 3 donor sites remaining. So these patients run out of spare parts, and 2 of those donor sites are injured. So what we start with is his right hand. He's right hand dominant. He says it doesn't feel as though it's part of him, and not surprisingly, really, because the fingers aren't attached to his carpus, his wrist, and his hand is insensate. So what we started with was with the poor nerve function. So the median and ulnar nerves, which are those 2 white stringy bits crossing the wound there, fortunately they were in continuity, but having excised the skin graft and scar that was surrounding them and replacing this with a free parascapular flap from his back, it allowed those nerves to recover their function. The next thing we did was to elevate the flap from his abdomen that was on the dorsum of the hand and replace the wires with the huge corticocancellous bone graft from his hip, fixed with plates spanning the proximal phalanges and the coalescence of the carpal bones. He's since also had other surgery for his wrist and to reposition his fingers and thumb. He has never been able to attempt prosthetic rehabilitation. The residual femur is unusually short. There's unstable scar overlying heterotopic bone and obvious contour deformity. So what we did was excise the scar and the heterotopic bone. By releasing the scar contractor, it reveals the original and the true skin defect. And then we transferred a free flap from his other thigh to resurface this. And this was only just achievable because of the proximity of the scars from the external fixator. They were very close to the blood supply of the flap. So he now dons his prosthesis full time. And unlike many of us in this room, has found his way up Ben Nevis. Pretty good, isn't it? So if you have been injured in this way, it is almost inevitable that you will require secondary reconstruction to be as good as you can be physically, which is what everybody wants to know. These are individuals who will make use of any additional function that you can make available to them, often in the most inspirational way. There is so much that we have learned from the experiences surgically that has been extrapolated to the NHS more widely, as we've heard from Nigel as well, for both acute and secondary reconstruction. And I would argue that it's probably the most important legacy of the conflict. When does it end? I would say that it only ends with the lives of those injured. So if you have been injured in this way, then you will need access to those with the right insight and expertise for the rest of your life. I have some examples to illustrate this point for you. So Cy, not the Cy you know, presented to me as a veteran 10 years after his injury. He was battle weary, having had enough of surgery. He's focused on the rest of his life, including his young family. He was also under the impression that nothing further could be done surgically, but he was struggling with the suspension of his socket and therefore prosthetic rehabilitation. So what I did was start by redraping the native skin on his thigh, loose now that the volume had dramatically reduced with loss of edema and muscle atrophy, excising much of the skin graft. I could then excise, I've moved one forward. So I could then excise the remaining skin graft and replace this with a free flap from his other thigh. So that completed the skin envelope and restored a smooth contour, and he is now pretty trouble-free. So Josh is a triple amputee. We had completed his secondary reconstruction when he sustained this injury to his left residual limb. He was in Spain, riding his recumbent bike downhill. He had a tyre blowout. He couldn't turn. He ran straight into an oncoming lorry and sustained these high energy injuries. So he's got a fractured neck of femur and a highly comminuted open fracture of the distal femur. So this is a limb and potentially life-threatening injury. His transfer to the UK was delayed as he was becoming increasingly unwell with sepsis. Unfortunately, the team in Spain had closed the wound early, which is one thing we know not to do. and that had also compromised the reduction of the fractured neck of femur, which was done later as well, which wouldn't have been the ideal order. So on arrival in the UK, he had life-threatening sepsis with renal injury. He had skin and muscle necrosis and a wound-draining pus. He later developed occlusive thrombus within the inferior vena cava below the filter that had been cited at the time of his original injuries. So he developed massive edema below the waist. So in parallel with the systemic treatment in intensive care, undertook a sort of series of procedures, excising the wound, and eventually delayed closure of the muscle over bone, preserving what length he still had, and a skin graft for what was now looking like a rather large residual skin defect. And I feared that he might need a free flap to resurface this. But fortunately, a year later, once the DVT had resolved and the scars had matured, I was able to redistribute the native skin on his residual limb and excise what was left of the skin graft, as I had done with Cbe previously. And here he is. He texted me these photographs with the phrase, "back in the game." And just finally, this is JJ. At my last appointment with JJ, we'd agreed not to arrange another appointment. All seemed well. I said, you must let me know if you think you need to see me again anytime. And the next morning, he sent me a text saying he developed a problem. His most severe injury involved his right upper limb, in particular this elbow. The metalwork had gradually loosened and eroded through an insensate flap on the back of the elbow, and the wound was draining pus and communicating with the metalwork and what was left of the joint. So again, a potentially limb-threatening problem here. I removed the involved metalwork and happily remains healed without evidence of bone sepsis. I hope that remains the case. And it was JJ who said that this was simply a side effect of being alive. So he reminds us all that these injuries may not age well, and that includes the uninjured joints of our amputees. And we must remember those who were injured as we do those who gave their lives.
I think to wrap it up, really, back across to Professor Tim Briggs. Tim.
Thank you. Just got one last slide, if we may. What I would say is that we've come a long way in 200 years, and I think you've seen that today. And I've always said that military care is world class, and I think you've seen that today from Nigel. And I think what they achieved at Afghan and also Iraq was absolutely phenomenal, really, for the patients. And I think that the NHS, and one of the missions I'm on, is to make sure that we provide the best possible care for our patients. And when I started this journey with veterans, I thought we could do better. I think the NHS has stepped up to the plate in the last 10 years significantly, I have to say. And I think Op Courage is a real exemplar of that. And I think that one of the things we've been able to do is reinforce the Armed Forces Covenant. It's now enshrined in law. And I think with our Veteran Aware and the VCHA, we've been able to really make an impact on that, and Guy's really been at the forefront of that. What we are developing is a network of hospitals. You do not have to be either an ex-medic who served in the armed forces or a veteran to treat veterans. You've got to understand them, and I think putting them in an environment where they're together, I think, is really important. So we, for instance, treat a lot of them at the RNOH. And what I wanted when we started was a network of NHS hospitals, and that's what we're going to get out of this, which is brilliant. Rehabilitation, I cannot emphasise how important I think that is. And the NHS in the last 20 years has downgraded the NHS rehab in terms of the cost cutting, but now we are completely changing that around, because if someone goes to Headley Court or Stamford Hall, where it is now, and they maximise that outcome, why do we want them to just come to the NHS and lose all that? What we want is rehabilitation units that are actually going to exemplar that. And we start building the first NHS Veterans Rehab Unit at the RNOH, and it's starting in about 2 months' time. And that's been a hell of a journey, but we've actually now got there. And we want more than one. Oswestry are building something very similar. So we know now we're going to, because what I want from this is enable seamless transition. And the key is to learn from each other. We can learn a huge amount from Nigel, from his experience at the front line, a lot of experience and cross-cutting and cross-working with the work Alex does. And what we want to make sure is that we provide the best long-term care and attention. We bring it all together with the NHS, the Armed Forces working together, and then the charities surround that, because I think also they play a huge role in actually providing that bit extra, which is what we want to see from all of them. So I would just like to thank you all for coming, for listening, and I think my colleagues have really told it as it is, and I think we should all be very proud of the work that everybody's done, what we've seen develop over the last 200 years, because we now have a service that's intertwined that I think we can all be proud of.
We hope you enjoyed this talk. For more information on our campaign and all of our work, come down and see us at Horse Guards or search Household Cavalry Museum.